Awesome. Welcome everyone to this social hour today. It's April 23rd. It's a great day. It's sunny outside. I'm excited. I'm Dave Kaiser, and here with me we have two great guests. Well, Alex is always here, but we have Alex, and with us we have Kathy Parkhurst. I was gonna let you guys maybe shout out your names or whatever, but
Oh,
actually, let's have Kathy say hello to everyone.
Hello, everyone. I'm so happy to be here with everyone today.
Nice. If you're joining us on Facebook, go ahead and say hello to Kathy in the chat. We've got Kathy here with us. She's going to be with us for the whole time. And Kathy is a member of our National Advisory Board or Chapter Advisory Board.
Chapter Advisory
I'm
Board.
looking, I'm looking right at your name title there. So it says CAB. All right, Chapter Advisory Board. And she's going to be with us to, always offer the professional coder biller perspective that Alex and I we're not quite there yet. We're working
no.
on it. So
Yeah.
that's why we have Kathy here because she's awesome. So,
Thanks.
um, Alex, we've had an interesting couple weeks or an interesting really month, it seems like. When was the
Yeah.
last time we went live? We did go live for a
We
minute.
did go live there. We went live. Our social hour time and schedule was lined up with the tunnel that we make, the celebration tunnel, I guess, where we clap as our HealthCon guests depart.
Yeah. Yeah, we brought you in for a send-off and it was only a few minutes, but just to show you how fun it is, even at the end of HealthCon, you get cheered as you walk away. So
Yes.
it's pretty
Yeah,
great.
it's super fun.
And Kathy, you were involved in HealthCon quite a bit, right? What was
Oh,
your
yeah.
about your involvement?
Yeah. Basically on the chapter advisory board, we do an officer appreciation breakfast. And we meet with officers who are at conference and we have networking sessions and just kind of talk about the struggles that officers may have, share ideas. And then throughout conference, we are kind of like ambassadors. You'll see us at the doors of general sessions, welcoming people to the food events, and we're also in the individual sessions, either as the virtual moderator or we will be introducing the speaker, room monitor, things like that. So we are everywhere during conference.
Are everywhere. Yeah, your involvement and help, our CAB members and our NAB members helping out with these events, we wouldn't be able to do them without you. There's so much to do. Like you said, there's so many different roles inside of each room just to make sure that the speaker's ready and that the
Mhm.
mic's going around the room for to answer people's questions. And then you were stationed as a virtual moderator in
Yes.
at one of the computers, right?
Yes.
So what were you doing with that?
Yeah. It was my first time doing that role. I've now completed all roles in my tenure. So, just making sure that everyone is taken care of in the virtual room. If they have questions, I can ask those questions on their behalf. Um,
Yeah, nice.
yeah.
Yeah, well, you did great because your first time doing it and you nailed it. So you've done all the roles, and we can now
Yes.
use you everywhere that we need you, which is
Yeah.
everywhere. So,
Yeah. Yeah. I mean, it's tons of fun. And do have to say that, being that we are assigned to a room, we don't have control over what speakers we listen to. But I'm in vascular surgery, but I can tell you that no matter what the speaker, what topic, what specialty, I took away something from absolutely every session that I was a part of.
that's
So,
awesome. Well,
yeah, it
that-
doesn't matter. Even if you can't get in a session that you wanted to, there's still something to be learned everywhere.
that's awesome. That's really feedback or great feedback. I know a lot of people can get bummed out if they're not able to get into the session that they want or whatever, but I love that.
Yeah.
And one of the things that we hear every year we may hear that maybe the MCs like Alex and I aren't that great, or we might hear that maybe the entertainment wasn't as fun as it's been in previous years, but we always hear that the educational content across
Yes.
the board is top notch.
Yes, absolutely.
Love that.
I look forward to it every year.
Yeah. So did
My
you have a,
first health con was 11 years ago, and I went after being an officer, I got the discount and I was hooked. First conference, I was like, I'm not missing one, and I
cool?
haven't.
Well, that's awesome. Well, what a great plug for conferences. Yeah. It's great to be involved. And if you can, especially if you have like an employer that will help pay for it or sponsor you to
Yeah.
go, I mean, definitely the way to go to get your education.
Hmm.
What was your first conference that you went to? You said 11 years ago?
Yeah, it was in Las Vegas.
Okay, Vegas
It
Con.
was at Paris and Bali.
Nice.
Yeah.
Awesome. Cool. Vegas. Yeah, we were just there last year. You went to
Yeah.
last year. Yeah,
Yes.
cool. You said you haven't missed one. Is that what you said?
Yeah. Well, I have to say I missed one health con because it was the year my daughter got married, but I went to regional instead.
Oh, okay. So you made up for it.
Yeah.
Well, maybe,
Priorities.
yeah, priorities. You got her
Yeah.
back. Right? Or you could have somehow convinced her to get married at whatever health con, whatever it was that year, whatever location, you know. It's kind of a
Oh,
two
we
for one.
they could have helped us on the stage
Yeah.
and
Ah,
and
that
just
would have
have a
been great.
little, yeah. Oh boy.
A special little thingy, a special, we'll just do a little ceremony right in the middle of a general session and
Well, as it was, the wedding was the day before I went to regional.
oh, the day before. Nice. Oh, well, that's cool.
Yeah.
That's fun. You got to send them off and then away you went.
Yep.
Which regional was it? Do you
It
remember
was
that?
in New York City.
Oh, okay, New York.
Yeah. Another one of my favorite places.
Awesome. Well, did you have well, and for you, Alex, too, did you have any favorite parts of HealthCon this year? Was there anything that stood out in particular?
Yeah, of course, as always, our members are just amazing, and I'm talking to a few of them in the chat right now. Um, Taylor King, I interviewed her for IME APC like a year or maybe even 2 years ago. Fun to meet her in person. Lori Harmillo. Okay, real quick. Crystal, Crystal Tompkins. I
Hmm.
remember at the Emerging Leaders um, banquet, she talked about how she doesn't feel like she'll ever maybe be in a traditional leadership role, but I don't know. I that humility I feel like will lead to those opportunities and the training that you've had and because sometimes I feel like that too. So that comment really stuck out, but we all have that opportunity to lead wherever we are and you know that Crystal, you're amazing and is so great to
Hmm.
hear you speak about the Emerging Leaders program.
Yeah, you guys haven't had an emerging leaders breakfast as well, I think one of the
Yeah.
mornings.
Yeah.
So you got to have a little special HealthCon breakfast with those that, excuse me, were involved in that. And it's cool. We're trying to add more and more to these events. And I know we're not really making them longer in time, and so it feels like we're packing more into a smaller amount of time, which, you know, is something to also look at. But we really are trying to fill them just full of really good stuff. Um, all the different committees that people are involved in, or emerging leaders or local chapter officers. If you're a teacher or a certified instructor, we've got sessions for you at conference, teach the teacher, sessions like that. So just a lot of good stuff. Um, yeah, the chat here, I was just getting it pulled up as well. Mary Lady says it is my favorite family reunion. So looks like Mary's talking about HealthCon. That's
Yes.
awesome. Yeah,
Yes.
great. And it is like family, right? You see a lot of people year after year and often we see them throughout the year in different virtual events as well. So oh, did you see the comment? Taylor King says this was my first HealthCon and hopefully I'll speak at a future one. So love that. I
Yes.
encourage anyone and everyone to get up and speak, even if you feel like you're just new to the industry and an amateur, you always have something to share. You always have a different perspective or a unique perspective that can be helpful to both experts and new people alike. So I love that. And our conference team is always looking for for people to participate. So
Mhm.
I don't know their email address right off the bat, the conference email. It could be conferences at aapc.com. If you're interested in speaking, email them. Sophia, I think those messages go directly to our conference coordinator, Sophia, and you can, see if you can get on the list to speak. Kathy, have you spoken?
I think I have not.
Yeah.
That is one of my goals as well.
Yeah, is this something you have a desire to, or
Yes.
yeah,
Yeah. Yeah. I'm in school right now for my bachelor's, so I've kind of put some things on hold until I should graduate at the end of the summer. So
nice.
after that, it is full steam ahead.
Yeah, nice. That'll free up a lot of time, I'm sure. Love it. All right, cool. Well, we've got some guests to bring in. And we can talk more probably about HealthCon. I'm sure that's just it's fun. There's a lot to talk about there. But let's bring in our first guest. She has written an article for us, and her name is Sabrina Skeldon. And the article she wrote for us is in the February issue of this year, and it is entitled "Give Your Physicians a Financial Literacy Checkup." So let's welcome Sabrina. Sabrina, go ahead and join us here. And how are you doing today?
I'm doing well.
All right. Well, like we talked about before the meeting, this is your first time here on Social Hour. So tell us a little bit about, give us a little bit of background, maybe where you're from and how you got into the industry. And we'll probably ask you more questions about it, but you can give us a little brief intro.
All right.
Uh-oh. Oh, there you are.
There we go.
Okay, I have a revenue cycle company called Physician Practice Guidance, and I work with small practices. I'm a healthcare attorney. I'm certified in medical billing coding, medical auditing, certified in risk adjustment coding. I got into this area because as a healthcare attorney, I saw how physicians got in trouble. And even though the False Claims Act is a very general act, but it's covering very specific um, issues and problems. And so the only way you could really, tease that out is by getting the certifications in the areas that I have.
That's awesome. So how long have you been doing the legal side of it?
I did the legal side of it
Has
for
it been the
11
majority of your
years.
career?
No, 11
Okay.
years. I was an assistant U.S. attorney and senior counsel to HHS-OIG.
Wow. Okay. So you've got a lot of experience then working at some higher levels of influence, I guess we should say. Well, that's fantastic. So what was it that prompted you to write this article? If you want to give us a little bit of background about the article, what kind of brought that up?
I wanted to educate providers on revenue cycle processes and help them understand the role of each member of their revenue cycle team.
Hmm. So has it been then are you saying that there's been some issues with that, or is it ongoing education that's needed in that area?
I can't speak to larger practices, but small practices are limited in their resources in terms of both personnel and technology, and they have a lack of education on revenue cycle practices. So they have more of a more difficulty in understanding their practice revenue and why it goes up and down and how they should manage it. So that was really part of what I wanted to get at.
Gotcha. So I would assume a lot of that has to do with mitigating errors, right? Looks like your article starts out by talking about some of those errors. What would be some examples of those that
Well,
that I guess you're seeing, the biggest issues with?
okay. When I'm speaking with um, small providers, I typically don't I talk with them about what the problems are and why they exist and what is the impact. That's hitting them from the perspective of their practice and its impact. So I never talk to them about, I never address it as, a gap in their processes or the failure to streamline a workflow. I'm talking about, say, with the front desk where most of their lost income is, that I start with the first three. I say, your front desk failed to get a new referral order from a PCP. And even though it's your practice to have the patient get that, if the main desk doesn't check it, then that patient visit is for free. Also, eligibility issues and prior authorization issues specific to payers. If they fail to follow through on what they're required to do, it has a dollar value. It has a loss to the practice. I tell them that this is your loss and it's non-recoverable because none of those errors is appealable. Then I go through copays and deductibles. The failure to collect copays and deductibles has resulted in a loss of X dollars. And I tell them now, from this point on, your ability to recover that money is reduced because you're going to have to file follow-up letters with the patient. So there is much less likelihood of success. And eligibility without insurance, there's no basis unless you treated the patient on a self-pay basis. There's a loss because of the eligibility. I finally go to what's probably the most important because it crosses over into the biller's role. I talk about the incorrect or insufficient information that's provided in the charting so that they can understand that it's going to lead to a delay in the collection of revenue and may even result in a loss of revenue if the denial is not corrected in a timely fashion or the rejection isn't corrected in a timely fashion, excuse me. They need to know the rejection process, and this may indicate that they are incorrectly or insufficiently staffed. I would ask them, how many days does it take your biller to correct a rejected claim before its submission? And then how many of those claims are time barred because they didn't rework them in time? I would tell them with the best practices that it's 24 to 48 hours. If that's the first thing that the biller should do when they get in the morning is work the rejected claims queue. From there, I would talk to them about denials and tell them the denial rate and the gross collection rate and the net collection rate because those numbers matter. They stick. From there, I would talk to them about the denials that are time barred and the denials that were never worked, because that is an indication that they're insufficiently staffed. From there, I would go to the main reasons for the denials. And I also would look to the extent to which you find more denials with a problem payer. And with that, I would say, having looked at the payer policy, that it reflects that this wasn't done. So he knows on a go-forward basis how to correct that problem. I would focus on
Specific. Well,
specific denials.
sorry. Was just chiming in with specific payers having
Yes,
certain tendencies.
yes. I mean,
What you're saying,
it's very easy to
turning
see.
those.
And it's important to identify because they are probably being denied for the same reason over and over again. And you just need to look at the payer policy to see what's being missed. Or, just, and in your corrected claims stating, this is in the chart or this is what we did, so that the corrected claim gets paid. Also, I focus on with the physician the denials that are attributed to a lack of alignment between coding and charting, or that are attributable to the physician not documenting sufficiently. With a lack of alignment, it could be an instance where the coder had a default coding connection and such that they would link, diagnoses based on the rules, whereas the physician may not do that. So there may not be a proper causal connection, and that could lead to a medical necessity denial. Also, he might chart history of, and to him that means both something in the active voice and something that's occurred in the past. To the coder, it only applies to something that's no longer an active condition. That kind of error again could lead to a medical necessity denial because the claim does not indicate what is actively being treated. Further, to the extent that the physician does not include all conditions, comorbidities, and complications that are actively being treated, the severity of the E&M code could be wrong, and you get a denial for that. Or again, you could be getting a medical necessity denial because you have not indicated the full extent of the treatment. Medical necessity denials are, for the most part, because the treatment plan is not for the covered indications of the payer policy. If the diagnoses aren't correct that are in the chart, that needs to be corrected. If there is an issue with, how he treats, what treatments he's providing for certain diagnoses that aren't covered by a payer policy, that's something he needs to know.
How
So
receptive have providers been?
they really do appreciate it. I mean, for them, this is a education. They had no knowledge of, where things can go wrong. Also, I mean, if they're using pull down menus to pick their codes and they just pick the unspecified one because it's not something they think a lot about, but the charting indicates the anatomical location and the laterality, but it's not in the code. And you get an unspecified denial that you didn't code to the highest level of specificity. That is a discussion that the coder and the physician should have. Also, where you see instances where the correct number of units of drugs is not captured in the chart or is miscoded, the two should speak. Or whether the units of service, where it's per joint, per lesion, per nerve, if that's not correct, there should be a discussion so that, there's an alignment and the claim is correct and the number of units are reported correctly. And
Yeah.
well, once the physician understands it and it's put to him, I mean, the report says what it says, but there needs to be a discussion and an ongoing discussion with the physician identifying what the problem is, why it occurred, and what was the impact to him financially. Money drives the discussion, and it's one he is receptive to. Once he understands that, he's pretty attuned to the parts of the revenue cycle that need to be addressed, and he's more able to monitor his own practice, which is very exciting when you see how they progress from whatever the audit results were, whatever it reflected in prior, periods. Everything that is forward looking that shows an improvement it's very exciting for the practice as well as for whoever audited them, because you see that, the education took. I also tell them, because doctors do this all the time, they say follow-up visits are very good for you. Well, so are follow-up audits. I mean, they serve the purpose of maintaining that level of achievement. To get a physician to the place where he agrees to a billing audit, that's the tough point. And there, again, you have to tell them, there may be a lot of, audit findings, but that's because of past results. This audit is the starting point, and you point to social proof. You show them and tell them that, other physicians have taken on or allowed or, permitted billing audits and really appreciated the results and implemented the plans and have seen, increased practice revenue. They will not try something that other people haven't. That's their, that's their inclination. So to open up the discussion and say that your colleagues do billing audits and they get this in the way of results, or that led them to recognize they need an additional biller and that the cost of the biller was justified because the income that they captured more than covered the cost. That kind of discussion is very helpful to helping a practice, capture as much of its revenue as it can.
Yeah, you had mentioned something about a provider's inability to appeal a denial. And so I wanted to ask you a little bit about that. Was that, excuse me, was that based on lack of documentation that they're unable to appeal it, or is that time like a sort of statute of limitations, like a time frame that after that certain point they can no longer appeal it?
Well,
I
as
guess
to
I'm
the three front desk errors that I talked about, eligibility, prior authorization, and lack of referrals, there is no appeal from that. That's just a mistake from which there is no appeal, and it just represents lost revenue. But other errors are appealable, or you can file corrected claims. You file a corrected claim or an appeal on a timely basis, prior to the cutoff of the timely filing deadline for filing an appeal. During that time frame, you can, file the corrected claim, provide the additional information, whatever is needed to help the payer, get enough information to pay the claim.
okay. That makes sense. I see the difference now in some of
Yeah.
the errors that are just lost money, lost revenue, and then
And
those that are, at the denial that can be appealed.
the doctor truly needs to understand the number of claims that are time barred and quantify every lost revenue number you can, so that they can see the total, hit they took because of the way they're staffed, because they don't have anybody to review their claims. If they're not working their denials, then it's the same as letting them lapse, because that will happen. If they're not properly staffed, they will not be able to work them, and they will not be able to recover revenue that they might have been able to with the proper effort.
You are definitely speaking my language because I work for a small practice.
Yeah.
And, staffing is an issue. And I'm a one-woman show. And it is very difficult to get
Many,
things done.
many physicians, I mean, if you're their coder slash biller, I mean, they're lucky. There are many practices that that are one doc shops that just have a practice manager, and the doctor has no idea all of
Yes.
what's being missed. He thinks, I got a check, I put it in the bank, that's my revenue. And that just, it's like you're missing so much. But there's only so much that one person can do. I mean, she's doing the scheduling, she's the front desk, she is making the deposits in the bank, and she's doing the posting of the payments, and she's sending out the letters. So she doesn't have the ability to cover everything, and she does not have the background. She has no knowledge to take on any role. So failure to recognize, that you're short-staffed or the limitations of the staff that you have is a problem. It will lead to a loss of revenue. And that's why anybody talking to the doctor needs to show him dollar figures. This is what was lost, because then it only hits home, you know.
Sorry about that. I lost connection for a minute, so hopefully I didn't. Hopefully the
No, you're
conversation kept
good.
going,
We're still going.
and hopefully I didn't have some weird look on my face. You know,
But also you
didn't
want
want
to give them, I mean, you can give them like a benchmark goal that 6 months into this audit, after this audit, we should revisit your practice and see how the improvements have improved overall performance. And I would expect your denial rate to have decreased X amount. My hope would be that I would see that, and that the days that it took to collect a payment was drastically reduced, because if nothing else, your rejections were being worked in a 24 to 48-hour time frame. So I give them, something to shoot for.
Yes.
And they do appreciate the
nice. So,
education.
Hey, our comments are lighting up in this, Sabrina. What you've shared has been amazing. Thank you so much for sharing your expertise. And I hope, I mean, you seem to enjoy this.
I love it. I mean, I love training providers, but I also love, helping them, walking them, seeing how they grow, seeing how their processes improve, being a part of that.
Well, thanks again for being with us, Sabrina. And hey, just so everyone knows, Sabrina and I have been working on getting her on here for months, and she's been very patient, and I'm so grateful that she's taken the time to share a little bit about herself and her article. Thanks,
Thank you.
Sabrina.
I appreciate the
thanks,
opportunity.
Sabrina.
Thank you.
Thanks for all the great info too. Take care. Cool. I think am I stable? I don't know if I'm if I'm
Well,
stable
what do you
or
mean? In what way, Dave?
not. That's a great question. Oh man, that is a great
No,
question.
you're great, and I'm gonna hop off in a sec, but just so Kathy knows, if Dave disappears again,
Okay.
you just run with it.
All right.
But be appropriate, Kathy. Come on now.
But be
I know.
appropriate, right?
I
Yeah,
know.
I'm not sure what happened. I had my internet just totally go out, and so I tried to hotspot it real quick, and that wasn't working too well, but I think I'm good. So,
Okay.
right, Alex, take care. We'll see you in
Okay,
a
I'll
couple.
talk to you guys later.
All right. All right.
Right. Right, Kathy. Well, we're not alone. We've got another guest. We've got
Yes,
Heather
we
Greene
do.
waiting in the wings here. So let's bring her in. Give her a second to join. That was really interesting. Sabrina's just I learned
Yeah.
so much.
It,
Just
I
the way.
mean, that is a topic after my own heart because I deal with that on the regular with my own practice and, trying to inform and educate my own
Yeah,
physicians.
I was gonna ask if we had time, if you had experience in the things that she was talking about
Oh,
to kind of chime in.
yeah,
So like it.
100%.
Nice. Well, Heather, welcome. How you
Hello,
doing today?
hello. I'm doing well. How are you all?
So
Yeah, I
good.
was listening in, and Sabrina definitely was preaching to the choir for all of us,
Yes.
gave us some really good advice. I'm going to have to go back and find that article so that I can read it and see what little nuggets of truth I can pull out of it.
Yes.
Um, and
Yeah, so good
find it
on. It
very
seems like she has a lot of
interesting.
experience in.
It
Yeah.
was nice from the perspective of, myself working for a small practice. A lot of things that you hear are geared toward larger practices. So this was especially useful for me today, dealing with a small practice.
Yeah, that's awesome. Cool. Well, Heather, you've written another article. Look at you. You've done it again. You do a lot. I mean, obviously you're great. You have so much experience. But the article is in last month's issue, right? The April 2025 issue. And it's about KPIs. It's called the 5 KPIs of a great CDI team.
Yes.
So give us a little bit of background about that. What prompted that? Is CDI a passion that you have? Kind of tell us.
Actually, it ties in so well with what Sabrina was saying. So in CDI, a lot of what we have to do is help physicians understand what they need to get into the document, not just for continuity of care, which is our main. I mean, we want to make sure that when a patient is taken care of, that when they go to see the next provider, that information is legible to the next provider. And just because it's in an EHR doesn't mean it's legible. Let's be clear on that. But also, are we putting the right words down in order to get paid and to keep our money? And so, like every process that you have, there are KPIs that go with that. And this article goes into it. Now, if you're just trying to start one for a small practice so that you have a communication from the back end, hey, we've got this denial and we need to work with the physician on documentation. You can take some of these basic KPIs and understand if your process is functioning well. And this is written really towards the inpatient side, but very easily, just with a change of the formula that's given in each KPI, you can change it for outpatient or inpatient. The big ones are that I would say is agreement rate. That's a huge one. And even if you have an EHR and you are using there's wonderful CDI software out there if you're able to afford it. But even if you're using that, you have to understand what the formula is, or the input's going to be incorrect. And I've worked with hospitals all over the United States, and one of the things that I find often is that CDI will think that the agreement rate is that they agree with what I think is going to be the diagnosis. Like, I did it
I
right.
agree with
I knew it was sepsis, or I knew it was pneumonia. But that's not what it's about. It's about, does the physician agree they should have been asked a question? Should you have bothered me? Should you have put another task for me to have to do based on what I'd written? And so that's really important to understand, because we know our physicians are just bombarded constantly with people asking and doing and needing. And so we have to make sure that those queries are limited and are accurate. And so getting that response rate is really, agreement rate is really, really important. If you're querying too much, then maybe physician education needs to happen. And so that you're working with the physician to actually say the things that need to be said so that you don't have to query. Or if you're not asking enough. And so you have to look at it. So in these KPIs, in all of them, 0, like, I never have to ask them a question, can be good and it can be bad, versus 100% I have to ask all the time. So even though we always think of 100% is, yay, we've done it, that's not always the case. We're human and we can ask when it shouldn't have been asked. And physicians can get tired of getting asked questions, and they'll say they shouldn't have been asked when they should have been asked. So you have to work through these things and understand. You have to do a lot of diving into the data to find out what that is. And, the same thing with the query rate. If I'm having to query more than maybe my counterpart, maybe we're on 2 different floors. Well, why am I having to query so much and my counterpart over here is querying half the time? Well, am I new? That could make me want to have to query more. Or do I have more complex cases? Do I have a new physician? Are the cases that they're looking at really simple, more simplistic inpatient cases, and mine are more complex? Those are things that all have to come into play when you're looking at the KPIs. And so I think it's always good to kind of go back to the basics in these, because whenever it's a formula, you have to stop and think, what's the formula for this? How do I get this rate? Because a rate is always a formula. And so I think it's important to go back and look, and you can add many more to this depending on what you're doing. And or temporarily add things if you have a new process coming into place, a new streamline of care, that may require more attention. You can add different KPIs to it. But the ones that I have listed in here are ones that really are tried and true. They've been around since the beginning of time. And and work well to give you a snapshot of how well your CDI team, your CDI program is working. And with that, in talking to her about it, a lot of times what I see in facilities and in physician offices is that they work in silos. And your denials team, which might literally be one person who might be the same person as your coder, if they don't have access to the physician to tell them, hey, we're getting this denial, the physician will never know what they documented was wrong. Physicians have habits just like the rest of us. They're human. Imagine that. And if we don't say, hey, when you write this, I get what you're saying, but nobody else is going to get it. They're not going to understand outside of that. And so please, you have to tell us. And we can talk about that on the payment side, but we can also talk about it on the patient side, because CDI have a responsibility of being that second pair of eyes to make sure the physician has documented everything, especially with at-risk patients, psych, mental health, elderly. We don't need, if we're sending them from one facility to the next, let's say they're in an acute care and going to a skilled nursing home, we need to make sure that we've documented everything that's done so that when they go to the next hospital, they don't have it all done again. Because nobody over here can understand the terminology that you used here that's hospital specific. And so, especially those patients who can't say, I think I already did this, or why am I, if they can't advocate for themselves. And so it's really important from a clinical standpoint that we clearly get documented when it needs to be there. The same thing goes when you're talking about patients. You give a patient a diagnosis, it's with them for a very, very long time. It's hard to get rid of. And so if you all of a sudden see like CHF, which this is a true story, pop up in a chart, and you don't have CHF, so then your insurance company thinks you have CHF. And your primary care starts thinking you have CHF because they're not a cardiologist. And then they want to put you on medication and you don't have it. And it's because somebody put it in there, maybe just accidentally. And so it changes everything. It changes your insurance rates. And so CDI should be working on that. Are all the diagnoses listed, supported? And is everything that they're doing, have we given it a name? Have we given it a diagnosis? If we're treating something, have we said this is what we're treating? And that helps the patient in the long run. So it's about, and so when you have a CDI program, it is about the facility, the physician, and the patient, really all together. And if everybody plays nicely in the sandbox, it should come out in the wash. So that's the whole purpose of it.
Mhm. Cool. And you've got those 5 KPIs to measure all of that, right?
Right. Yes.
Using that as sort of the formulas and the checks and the things that you can look back at last month or whatever. How often are you reviewing all of these different KPIs? Is this like a weekly
Monthly.
meeting? Is this a monthly team meeting?
Yeah. You would want to look at it. And actually what's interesting for CDI a lot of times is they know their own metrics. So if I'm working as a CDI and not a manager, I should know what my own metrics are. I should know where I stand, and I should know where I stand in my team. As well as the manager will know more about what's going on. I should know that if I'm, I sit next to my counterpart and she's querying half the time, I need to understand that I have more difficult cases, and that's why this comes this way, because their documentation requires more of it. And so I don't know, and I try to think about that. It's one of those things where it's not just the manager needs to understand this. The CDI specialist needs to understand what these KPIs are and what they can do as an individual to make sure that we're doing the best that we can in terms of protecting the physician, the facility, and the patient.
Do you have any advice for new CDI professionals?
For
And
new CDI?
understanding? Yeah.
Yeah, study all the time. make sure that you trust but verify. Um, be willing to communicate, be willing to learn from anyone, but also be willing to teach. And so it's a humility and a confidence that you have to have, where you can say, I don't know this. And usually physicians will sit down with you and say, this is how it works. This is what I'm doing. And then you can take and research that and see how it plays into it. If your facility allows it, you can go in and watch the procedure so that you can see how the procedures are performed, if they will allow it. It's one of the most awesome things to actually see it live. It changes, even for coders, it changes everything. YouTube is awesome for watching this kind of stuff. So I watch surgeries all the time on YouTube because you can see what's happening, those new procedures, and you're just like, oh, wow, I had no idea that's what it was. And so it helps you to begin to understand what it should look like. And I think those are important things to take a look at. If you've got the stomach for it. So, be aware, I wouldn't eat dinner while you're watching some of the procedures. But, it's always good to learn and have a better understanding of what's actually happening.
Yeah.
I think
Yeah,
those
especially
things are
those
important.
gynecology ones. Dr. Pimple Popper. I
Ooh.
want to watch those while you're eating. Um, yeah, that's really fascinating. The world of CDI and how that world and these teams are expanding. Are you seeing more and more practices? I guess, Kathy, this is a question for you too. Are you seeing more and more practices that have a dedicated team, or is it just like, well, we have a CDI specialist here, or or do they have these full-on teams that are, I guess recording all these metrics and going to town, making sure everything's perfect? Or is it just more of an add-on to people's roles that they're already doing? I guess I'm just curious.
If my experience in my area, it's more of an add-on. The hospitals will have CDI teams, maybe some of your larger multi-specialty practices will, but again, for myself, I am a
You are.
one-woman show.
Yep. And you have to learn, and that's a lot of hats to wear. I can tell you,
Yes.
even in small facilities, um, you know, my recommendation, and it always has been, and I think that there are several organizations that agree, is in your team have physicians, clinical staff, which usually is an RN, not always, but usually, and a coder. And sometimes they're not CDI separate. Sometimes it's your coder. It
Yes.
might be your quality, a quality nurse, that's the CDI nurse, and the chief of staff. So, it's a matter of what it comes out to be. But having the perspective of all three keeps the ship moving in a direction that it should. If you have all RNs, you may forget or lose sight of coding guidelines and coding clinics and things, denials and things that insurance that's not happening. And so you have to kind of pull them back and say, okay, we have to follow this way. Having the physician on board helps with, no, this is clinically, this is how this works. And the RNs can do that as well. But an RN is not a physician. A coder is not a physician, an RN, vice versa. And very rarely are they coders. And so we have to bring our perspective into it. So again, we teach and we learn. And so that we can make that work. I think that is vital, and that's hard to do in a small practice.
Yes. Yeah.
Truly.
And, you also have the issue of prior authorizations. Are they documenting so that when that authorization for that procedure is requested, it's going to go right through? Or are you going to need more documentation? Or is the physician then going to have to write a letter of medical necessity because their office note was not quite up to snuff?
Yep. And we would see that on
More
the
time, more work, more
Yes.
communication has to happen, less they
Yeah.
can treat patients. So it just affects everything that if you're not getting
Right.
it right the first time.
Right, and the denial. So you're talking about pre-auth. So in the facility, they'll get pre-auth for a diagnosis, but then after chart and after study, what brought the patient
Yes,
in was not what was pre-certed.
right.
And they come back to the coding department and go, "You coded this wrong." No, no,
No, it
we
was
coded what was
documented.
documented. So you might have thought you were treating something else, but what you wrote down, this is what we coded. I'm watching some of the chat and they're saying the documentation rule. When it comes down to it, it's what's in the chart. And
Yes.
so, and they have to go back through that. And sometimes they lose the stay. They can't get it retroed.
Yeah, no,
So, being mindful of that,
Really,
that's where CDI,
because they
yeah,
can't, because they don't have a good enough supporting documentation.
right.
Is that
Well, they can't support what they pre-auth.
right.
can't support
So,
what they pre-op, and so they're like, well, they're just out, whatever the difference is. Or
mhm.
do they try and pass that on to the patient? But have they were, I guess,
I don't
can they
think
not
they
do
Yeah,
that?
no,
Because they got the
no.
pre-authorization, but it was for a different amount that was agreed on. I'm just learning, so
Yeah.
Yes,
Yeah, or different
no,
condition. Yeah. So,
yeah,
and they didn't timely call the insurance company and go, "Hey, we really thought it was A, but it's really looking like it's B and we need a new pre-auth."
yes.
So those things happen. So,
yeah, this is
um,
fascinating information, and the chat's loving it too. A lot of people are, saying great information that both you and Sabrina have shared about this. So,
mhm.
and Kathy, your insight's great too. Did you want to briefly talk a little bit about the workshop that you've got coming up? Do
Yes, I'm
a little plug for that while you
ex
have a couple minutes left?
yes, well, I'm so excited. So this Friday, we are going to be doing an inpatient workshop, and we are going through PCS coding of spinal surgeries, amputations, and joint replacement. And it is going to be Mary Leidy, Claire Stevenson, and myself that will be, this is a 4-hour workshop. So it'll be all day Friday. I think it's 10 a.m. Eastern time. And I'm going off memory here, so if I'm wrong, but we've put the information together and we've built it out, and the workbook itself is simply amazing. It has so much good information in it. So if you're an inpatient coder or you're just curious about it, because we talk about the procedure as well, come and join because it's going to be a good workshop. It's going, and we're tackling some of those difficult questions that are really hard to do in an hour session. Can't really take on the gray, or where those really difficult questions have to be asked. Here in a workshop, we can go into that and take a deeper dive into it. So I think it's going to be an excellent workshop, and we'd love to see everybody attend. And it's getting good response back now. And so if you're available, think about it. It's gonna be really good.
Great. So that's this Friday. So 2 days from now. And it's I'm looking at the time, it's 10:30 Eastern. So
10:30.
starting at
Okay.
10:30 Eastern, 4 hours long. And really it's 6 CEUs that you get from these workshops too. So you also get your CEUs from it along with the educational content, which is great. So
Okay.
and it's a pretty cost-effective way to get CEUs if you're needing CEUs. So
Right. Yeah.
um, check it out. Well, this has been fun, Heather, Kathy, and Sabrina. You know, thank you,
Yes.
Sabrina. But thank you, Heather, for joining us, and thank you, Kathy, for being on here today, and also Alex. We'll see Alex probably full time next in 2 weeks, but um, thank you
No,
all.
this was fun.
Glad you enjoyed it.
All
Okay,
right.
we'll see y'all next time.
Okay,
Thanks. All right. Bye-bye.
bye.